Welcome to Lecture for Research Methods. We'll be talking about clinical outcome research. So, starting off, clinical outcome research basically looks at the question of, does therapy work? Which therapies work? And so, what do we know from all the research that's been done? Does therapy, in fact, work? Yes, for some people, some of the time. And that's about as good as we can say. A related question is, does the type of therapy that you're doing matter? If you're doing cognitive behavioral therapy versus Gestalt therapy, will one be better than the other? And the answer to that, even less clear. Maybe. A lot of times whenever studies looking at different types of therapies are compared at once, kind of across studies, we'll find no difference in type of therapy. However, in an individual study that compares two treatments head-to-head, it's not uncommon to find differences between two types of therapy. So depending on which data you're looking at, that will affect how you answer this question. So type of therapy probably does matter. How much it matters is probably a better question, because there are probably some other things that are important. So what are those things that are important? What are the kind of common factors that, okay, regardless of what type of therapy you're doing, if you're doing these types of things, or if these things are present, success, better outcome is more likely or less likely. And a lot of debate about what the common factors are, about what is important, but some things that have pretty solid support. In general, the therapeutic relationship, and lots of things about the therapeutic relationship. Harkening back to kind of Rogers' view of empathy and genuineness and unconditional positive regard. There's something about the attitude of the therapist toward the client that is predictive of outcome, and also the client's experience of the therapist as kind of caring and warm, that seems to be important. But nailing down exactly what properties of the relationship, what type of relationship is best, is more difficult. But we know that that relationship is really important. Another thing which we have less control over is severity of the problem, with kind of the common sense thing being that more difficult problems are more difficult to treat, and less difficult problems show better outcomes, regardless of what type of therapy you're doing. And then another thing, which is probably related to severity of problem and related to therapeutic relationship, are the expectations of the therapist and the client. And it's one of those just kind of things that you'll see across different types of research, that this kind of expectancy effect, that whenever there's an expectation of a good outcome is more likely. When one or both parties don't think it's going to go well, it's probably not going to go well. So not a real surprising thing there, but an important factor to keep in mind. So what we've talked about so far, it seems fairly vague about, with all the years of research on therapy, this is all we know. So why don't we know more? Well, a lot of reasons, but one of the big reasons is what we talk about, the Clinician-Researcher Divide, that there's this gap between clinicians doing therapy, doing treatment, doing counseling, and the researchers studying these phenomena, and the two haven't communicated clearly enough to advance the field as far as maybe it could be advanced or should be advanced. So, a little history on the Clinician-Researcher Divide. In the 50s and the 60s, part of the reason for the divide was just kind of poor methodology in clinical research. So clinicians said, well, this isn't very useful what you're telling us, because the way you're looking at this problem is done really poorly. And also, the studies coming out were saying, hey, therapy doesn't seem to work. But part of the reason it didn't seem to work was because the methodology was crappish. So that was a problem. But then in the 70s and 80s, there was better methodology, but the divide continued because there was a perception that, okay, well, yeah, you've got a pretty neat study there, but the participants in your research study aren't anything like the people I see in my clinic, because you used all these criteria, only let certain people in with no comorbid diagnoses and all this stuff. So that research is really good, and yeah, I believe that the treatment worked for that group of people, but the people I see aren't like that group of people, therefore it's not applicable to what I'm doing. And in the 90s forward, kind of grew into this kind of more nuanced discussion about, okay, well, now I see you're talking about there's this statistically significant difference between groups. You have a statistically significant effect of some treatment, but how I know that that's clinically significant? So you say this treatment is better than this one in terms of these numbers are different, and I believe those numbers are different, but will the people I treat be different in ways that are important and meaningful in the real world? And this kind of led to this a distinction and ongoing discussion about the difference between efficacy research and effectiveness research. And the two types of research really differ on their goal. And the researchers were primarily doing efficacy research, and the clinicians were really asking for more effectiveness research. So to better understand, let's talk a little bit about those two types of research. Efficacy research is asking the question, can a treatment work? So can this one be better than this one? Right. So when we're asking, can something work, obviously the focus is really going to be on internal validity. So we're going to have lots of experimental control, and we're going to do all these things in such a way that we can answer the question, is it possible that this treatment will lead to improvement in someone? Right? And that's the goal of efficacy research. Can this treatment be efficacious? Can it work? Effectiveness research has a different goal. It's, well, not can it work, not can it work in a lab, does it work? Does it work in the real world? So obviously when we're talking about real world, we're talking about a greater focus on external validity. So you've shown it can work in the lab. What I want to know is, does it work whenever you tell therapists to do this type of treatment? Do clients get better? Can we afford to do this type of treatment? Do we have the resources available to reconstruct what you did in the lab? So the choices that a researcher makes when designing an outcome study will depend on what their goal is, whether or not they're more interested in doing kind of efficacy research or effectiveness research. So let's talk a little bit now about the choices that a researcher makes when designing an outcome study, looking at the effectiveness of the treatment. One of the first things you'll look at, and you'll have to decide, is the inclusion and exclusion criteria. Right? So for efficacy research, when the focus is on internal validity, you're probably going to have fairly rigid, fairly strict inclusion-exclusion criteria, right? Because you want to create this homogeneous sample where everybody is pretty much alike. If you're looking at a treatment for depression, obviously you want everybody in there to have depression, and they all have to have a certain level of depression. You don't want all different kinds of, some really severe, some mild, in your group, because there's going to be more noise in the data. And you also don't want people who have depression and some other diagnosis, right? Who also have a substance abuse disorder, or also have a personality disorder, or an anxiety disorder, right? You want to exclude all those people, so you have this kind of pure group people who all have depression at a similar level. And if you have that, then it's easier to see an effect of treatment, right? There's less variability in the group, then it's easier to see the between groups variability. If you're comparing one group to another, if you're doing pre-post, it's easier to see the effect of a treatment if everybody is more similar. Obviously, if your goal is effectiveness research, when you see if this really will work in the real world, those inclusion-exclusion criteria don't fit, right? Because you can't, well, when treating people in the real world and they walk in the door, you can't say, oh, you have criteria for major depressive disorder? Okay, I'll see you. Oh, wait, you have an anxiety disorder too? No, sorry, I can't see you. I only treat people who only have major depressive disorder. Doesn't work that way. And also, what doesn't seem to be real world is very few people have only one diagnosis, right? Comorbidity seems to be the rule rather than the exception for people experiencing psychopathology. So there's a real difference there between efficacy research and effectiveness research, how strict your inclusion-exclusion criteria are. Another thing that both types of research should have is a control group. It's kind of a minimal level of design for anytime you want to look at cause and effect. But there's probably more of an emphasis on an appropriate control group in efficacy research than effectiveness research, and there's maybe different choices you would make on what type of control group you wanted. For efficacy research, probably the preferred type would be a wait list where you really have no treatment versus some treatment. So everybody comes in, and then half the people are going to be put on a wait list where they don't get any treatment for a month or 2 months, however long it's going to be. Then you have another group of people that come in and they start treatment right away. And the argument out there is that this might not be, people who participate in a study like that might not be like real clients. Right? Because real clients don't typically come in and say, oh, you can't see me for a month, okay, I'll wait. They go see another therapist. Right? So people who are willing to wait, who, if they don't know which group they're going to be in, they're willing to participate in an experiment where they might have to wait a month, people like that might be different than real-world clients. They might and probably have less severe problems, right? Which will make your efficacy research not look like the clients that you see in the real world. So that argument is there. There aren't really data yet to support that, but it makes sense that it would be true. So it is a bit of a concern. Another type of control group that is you might think about using is kind of a placebo group, where you're going to provide a non-active or inert treatment compared to your active treatment. Where you're going to have people maybe just receive supportive therapy. The problem with comparing a treatment to inert treatment is the inert or non-active treatment probably isn't inert. Whenever people get supportive therapy, they're still getting an active treatment. They may not be getting your particular experiences of the active treatment, but they're getting something, and they may get better, and probably will get better if they're meeting with a trained therapist. So something that's supposed to be inert may not really be inert, so that can be a bit problematic. So then another option, which is probably more likely to be used in effectiveness research, is comparing some new treatment to treatment as usual. So what's the typical treatment in a clinical setting, in a community setting, and then compare people that are receiving the typical treatment to some new treatment. So deciding which one you're going to do may depend on the goals of your research. A related one is random assignment of participants to levels of treatment, so to get the treatment or get to be in the control group. This is something that you definitely have to do for efficacy research. Right? It's part of the requirement for internal validity. You have to be able to assign people to levels of the independent variable, and here treatment is the independent variable. It's a bit of a problem with effectiveness research, mostly in terms of the people who would be doing the effectiveness research don't want to do that. There's kind of ethical concerns about randomly assigning half the people to a treatment that is thought to be less effective. Why not get everybody the good treatment? And also, just kind of real world effectiveness research often is done kind of post hoc or after the fact. So we'll look at kind of these existing groups, people who got this treatment versus people who got this other treatment. Are they different? But we didn't assign them to groups, but we're looking kind of existing data because it existed in the real world, which provides greater external validity than this kind of artificially assigning people to. You come to the clinic, but okay, now you have to go across town to this other clinic because that's where they're doing the treatment that you've been randomly assigned to. Another decision is the degree to which you want to standardize treatment. So for efficacy research, obviously there's a high level of standardization where everybody in the treatment and the experimental condition gets the same treatment. Everybody in the control gets the same, whatever the control is, same type of wait list, same type of placebo, whatever. But there's lots of control, right? And that's achieved usually through treatment manuals, right? Where session 1 you're going to do this, session 2 you're going to do this, session 3 you're going to do this, and you train therapists extensively to make sure that they know the manual and they know what they're supposed to do at different stages of therapy. Right? And the more you do that, the more it'll look like efficacy research. In the real world, even though therapists may consult treatment manuals, there's much more freedom to deviate from the manual and improvise and be spontaneous. And there are therapists that say, we don't. If you find this manual works, that's great, but I don't want to use it because I'm not a mechanic. I don't want to say, okay, this person comes in, okay, they're a 94 Toyota Tercel. this must be the problem, right? I went to school, I have these skills, I want to be able to use them. I don't just want to be this kind of robotic implementer of some set manual. That's not why I got into this business. So there's a resistance among clinicians sometimes to use treatment manuals the way that they're used in efficacy research. The other part of standardization is the setting of service delivery. Again, for efficacy research, when you want to maximize internal validity, right, you want to have as much experimental control as possible, so you're probably going to deliver the services in some sort of lab setting. Not necessarily a lab like your a high school science lab, but some clinic that's set up to only service those individuals, and it has probably some specialized equipment for recording and all these things. But it won't be the type of setting necessarily that most people would go to in the real world. It's not your neighborhood therapist, it's not your local MHMR. Whereas effectiveness research would look at, okay, well, where is therapy typically delivered? Where do these people typically go when they need help? How are they referred? Where do they get the services? That's where we should study the effectiveness of treatment. And efficacy says, that would be great, but we want control over it to, again, eliminate unnecessary variability and noise in the data so we can see if something is working. And the last choice you have to make is how you're going to measure the outcome. And for efficacy research, typically it's symptom focused. So in terms of did it work, did the symptoms reduce, which is fairly straightforward and makes some sense. But kind of real-world clinicians know that, okay, symptom reduction is good, but it's not the most important thing for my client. The most important thing for my client might be, were they able to go back to work? Were they able to get their children back from CPS? If they had kind of a panic disorder and agoraphobia, are they able to go to the grocery store now without somebody accompanying them? So kind of quality of life measurements might be more important for effectiveness. So is your life better after treatment versus just are you having fewer hallucinations? Because if you have fewer hallucinations but your life's not any better, then a therapist might say, well, treatment didn't work. We managed some symptoms, but you're not better. Your life isn't better. You're not happy. You're not more fulfilled. Whatever. So given the different goals of research, what's assessed can be different. And another kind of level that effectiveness research looks at is the cost effectiveness of an intervention. Efficacy, again, is just, does it work? In the real world, does it work, and how much does it cost to do that? And that's something that you probably wouldn't assess when doing efficacy research. Okay, so all these choices are things you have to think about when designing an outcome study, and the choices you make will probably be influenced by the goal of your research, whether you're looking more at efficacy or more at effectiveness. Okay, so we can see that the choices you make will determine what type of research you do. And the two types of research, there's a bit of a gap between them, and I'd say it mirrors the gap between clinicians and researchers. So you say, okay, well, great, there's a gap, there's differences. Why does it matter? Who cares if there's a gap? Different strokes for different folks, right? Well, it matters for one, the main reason, quality of care for our clients. If the things that clinicians do, the effectiveness research, isn't influenced at all by efficacy research, then there's a bit of lost confidence there in whether or not what we're doing is based on strong, solid science, right? So it happened to work, the treatment happened to work in this one setting, but now it didn't work in this other setting, and we don't know why, right? You don't know the mechanism, because the way to isolate mechanisms of change is typically doing efficacy research, right? All we know is, okay, well, it worked here and didn't work here, but you can't answer the question of why. That's harder to do when your focus is on external validity. If we just did efficacy research and only read that, then we'd have that problem. Okay, we kind of know why some people change, but we wouldn't have a very good idea of which people different treatments would be more likely to be effective for, or which therapies to use. Okay, you found all of these different therapies can be effective. Well, which one would be most effective for the type of people that I'm going to see? And efficacy research by itself can't answer that question. So if we relied on just one or the other, and didn't kind of try to bridge the gap, the quality of care for our patients would likely suffer. Another reason, funding for care at a variety of levels is tied to data, right? It's empirically driven, and this is at the insurance level, right? There are some insurers that will say that they'll reimburse for treatments that are empirically validated treatments, and they won't. If you want to do this stuff, that's great, but we can't pay you for it because there's no evidence that it works, right? So that's important. And then at kind of the government funding level, it's also tied to data in terms of what types of care will be funded and will be provided at state and federal agencies. So at the VA system, are they going to pay for if you want to do a cognitive behavioral therapy group? Can you do that in that state-funded institution or not? Well, a lot of that depends on if there are data there to support doing that intervention for the group that you want to do it with. In terms of training therapists, right? You're at a state-supported institution. If there's no evidence that therapy works, then there's no point in training therapists, and that money goes away, and the whole profession goes away, and that would be a problem because we know that it works, but we have to show that it works and who it works for, when it works, and then ideally why it works would also be nice. And the third thing is direction for future research. So we always think about, well, we need to bridge the gap because of the effect on practice. And that's important to us, but it's also important to realize that research divorced from practical application completely is going to eventually grow stale, right? They can only learn so much. So the new questions for basic researchers will come from the applied world, right? Until we say, well, you said that this treatment worked. We found that it didn't. We're finding that it's not effective for people who didn't have English as their primary language. And the basic researchers go, wow, that's an interesting question. Let's look at that. So new questions for them often come from the applied side of the house. So for them, it's important to bridge the gap as well. It's not just for clinicians and patients or clients that it's important to bridge the gap. It's also important for those basic researchers in terms of coming up with new questions. Okay, so how do we bridge the gap? Well, there are a couple of ideas. Your book talks about the NIMH, the National Institute for Mental Health proposal, which talks about doing this kind of hybrid of efficacy effectiveness research, right? Where basically they say, okay, let's make efficacy research look a little bit more like effectiveness research, right? So more emphasis on external validity. So in terms of those inclusion-exclusion criteria, let's try to loosen those up a bit, right? And in terms of outcome measures, let's increase the types of things that we measure as outcomes beyond just measuring symptoms. But they're not saying go wholeheartedly into effectiveness research. Try to maintain some of the control that is valued so much in efficacy research, but loosen some of the controls in kind of important areas. And then along with that, so trying to kind of loosening up this efficacy research to make it look more like real-world situations, more like effectiveness research. In addition to that, develop new research designs and statistics to address the problems created with regard to internal validity. So when you start loosening these things up, the efficacy researchers think, oh my gosh, the internal validity is starting to go down, this is a problem. And so the recommendation is we'll come up with new ways to do research and new stats to address that. The NIMH didn't specify what these new designs would be, but said that we should come up with them. So a good idea, but not necessarily practical or practicable currently. But at least gives us directions. Okay, well, if we're going to give up some internal validity, how can we get some of it back using statistics or really kind of clever methodology? So up to you to figure that out, I guess. Another idea would be looking at multi-site efficacy effectiveness clinics. Here, where you'd have a lot of different clinics focusing on different issues. So some clinics focusing on really kind of efficacy issues, some focusing on the application. So what was generated out of those efficacy type studies at certain clinics would then be examined in another clinic, looking at the effectiveness of that treatment, and all using kind of a common outcome measure so we can compare across these kind of different cooperating clinics, which again, good idea, but level of practicality and how possible is it that this would happen, uncertain, depending on the amount of funding that's available to run such a large project as we would need for something like this. And the other thing, which is probably the most practical, would just be to continue looking at meta-analyses. Meta-analyses across efficacy studies and across effectiveness studies, and then across both types of studies, because something that's kind of interesting to me anyway is when you look at the data, effect sizes in efficacy research and effectiveness research seem to be similar, right? Compare if it's a certain type of treatment, and one study was an efficacy study looking at that treatment, another was an effectiveness study looking at that treatment, the effect sizes don't seem to be that different depending on one type of treatment or the other. And you would think the efficacy studies would have higher effect sizes because they have greater control. And sometimes that's true. So we know, like, if we have greater adherence to a treatment manual, effect sizes tend to be higher. But overall, if we look at some good effectiveness studies, the effect sizes are just as good there. So we can start looking across these different types of studies to determine evidence for which treatments are good, which are efficacious and effective, and maybe which ones may be better than or superior to others for particular clients, right? Particular problems or regions, or however you want to look at the data. Some other ideas would be to instead of just doing, okay, we're going to standardized treatment or not standardized treatment, but actually do multiple levels of standardization of treatment and examine the impact of level of treatment standardization. So when you do a study, maybe kind of using an efficacy model, so you can have a treatment manual and everybody has to do it, but also have another group or maybe two more groups where, okay, one group of therapists has to follow the manual 100%, another group is told follow it pretty closely, but you have some freedom, and then the third group is told here's the manual, but you have complete freedom. And then say, okay, within that study, did level of treatment adherence matter? And if not, then we don't worry as much about level of standardization. So make it an empirical question rather than just assuming that treatment standardization is important, because it might be important for some treatments, but not others. So which treatments does it really matter that you have to follow the manual if you're going to do this? But if you're working with this problem, maybe following the manual 100% doesn't matter so much. That's an important question. Another idea would be to study integrated interventions. Think about kind of packages of assessment, therapy, social services, because typically in efficacy studies you look at, okay, this treatment, and regardless of or excluding people who get any other type of stuff. You know, if you have a social caseworker, no, you can't be in our study. We look for people where their only point of contact for any kind of therapeutic services will be this one therapist. So one idea is to use kind of efficacy methodology with a lot of control, but looking at these packages, okay, where you have these maybe different tracks. Okay, well, where everybody will start with an assessment, and if depending on assessment results, you're going to go here, here, or here. You're going to get this type of therapy and these services, or this type of therapy and these services, or just these services and no therapy. But you're going to assign people based on the assessment, and then can compare those groups. So you're trying to exert some control, but you're no longer looking at therapy in isolation because it's not typically delivered in isolation. Another idea, we've touched on this already, is to look more at, for the control condition, not doing placebo or waitlist, but looking at comparing some new treatment to a usual care control condition. So, and the idea for this, the reason for this really is to make it more palatable to clinicians. Whenever you want to come in and do research in a clinic setting, clinicians don't really want to say, okay, well, yeah, I'm okay with half of my clients getting some treatment that you don't think is effective. Right? They want to say, okay, half of my clients will continue doing whatever we're doing now, and then the other half or some portion will get some new treatment. It's more acceptable to clinicians, and also from a pragmatic standpoint, it makes sense, because why provide a new treatment if it's not better than what you're already doing, right? The new treatment, oh, it works, great, but if it works just as well as what you're already doing, why invest the resources in doing this new treatment if it doesn't work any better than what you're already doing? Another idea would be the donut model of participant recruitment. So this is really kind of hybridization of efficacy and effectiveness research. So the donut, think about the core of the donut being, so some people selected into your sample will be the core, and they'll be people that use the kind of those strict inclusion-exclusion criteria, right? There are people who are all homogeneous and exactly the same, the type of people you would typically recruit for an efficacy study. And then the outer ring would be another section of participants who you don't use the inclusion-exclusion criteria, and they'd be more like people you would see in the real world. And then you can look at the data separately, and and see if there are differences. So did the treatment work for the core but not the periphery, or if it worked or didn't work, whichever way. If the effect was the same for both groups, then you can look at the combined data. Right? That way you're kind of doing an efficacy and an effectiveness research at the same time. Right? So it's almost like putting an effectiveness sample and an efficacy sample and doing them in one study, which will save time and resources rather than having to just replicate an efficacy study later in an effectiveness study. And then the last thing is to just also think about doing research not just on do people get better, but on pragmatic issues. So applying some of the kind of controls and the methodology and statistics that work so well in efficacy research to questions that are more typically addressed in effectiveness research, like cost effectiveness. Given the amount of resources, money, time, whatever that it takes to implement this treatment compared to all the resources it takes to implement this other treatment, are the outcomes significantly different when considering those differences in resources? And that's something that hasn't typically been looked at using the level of control and kind of random assignment type things that are seen in efficacy research. So that's one more recommendation to bridge the gap. So a lot of different things to do, and on kind of a individual level, the easiest thing to do, not the easiest, but one of the simplest things to do is for clinicians like yourselves to read journal articles, right? So don't just rely on textbooks, don't just rely on what you hear in classes or what you learn from a supervisor. Go to the journals where the research is being published and read about the latest stuff, what people are finding that seems to be effective, and read it critically and try to determine, okay, what they found, looking at the type of sample they have, the type of methodology, how applicable is that to the type of people I would work with, and make that decision for yourself about the degree to which you can integrate those findings into your work. Okay? Take care.